Hey, Leanne. Hey, Rafaela.
Hola. I'm gonna mute myself because my head hurts,
Okay.
but I'll be here.
It's my class.
Hi, Rhonda.
Hi. Can you hear me?
I can.
Sweet. Chad's harassing me.
Tell Chad I said, what's up?
Can you see him?
What's up, brother?
It's crazy around here.
Hey, Gabriella. How are you? Hi, Mark. Hi. Hey, Rachel. Hey, Emily. Hey, Brittany. Hey, Renee. And I see Desiree and Becky and Brenda. Matthew's out there. Alicia Green. All right, cool. So just FYI, my preference is that you keep your video on just to confirm your attendance in class. If you start to break up because of poor connection, you have my permission to, shut your video down. But I do prefer that people have their videos on. I saw a strange clip the other day. I saw, and I think it was from NOC, actually. I believe it was from Northern Oklahoma College. So, a lot of people that aren't used to teaching this way, which I've taught a class this way before, so it's not completely outside of what I'm used to. But one guy from NOC was teaching a class, and a student apparently forgot that they had class at that time because, everything's so messed up. We don't have our schedules. We're doing weird stuff right now. So the professor starts to question, hey, what are you doing? Because his video is kind of moving back and forth. You could tell he was outside. And he was dressed in fatigues. He's dressed in camouflage. And so he said, I'm cleaning a turkey. And so he had shot a turkey and it was dressing the turkey out in the field. So anyway, the professor played it off pretty cool. He's like, well, let me see its beard. So he held up the beard from the bird. So anyway, I had a pretty good chuckle with that.
He used to be my biology teacher.
Do what?
He was my biology teacher.
Oh, you saw the clip too?
Yeah, that's how he always is. He's actually a veterinarian also.
Oh, cool. Okay. Well, so it was a little bit related to class, I guess, if you're dealing with biology.
Also, Jenny says that she's still trying to sign on and to let you know.
Who said that?
Got the text.
Okay.
Jenny.
Okay, thanks.
Her Zoom wasn't working, I guess, because she's been trying for the past probably 10 minutes to get on.
Okay. I see. I think she popped on there at the bottom. So.
Okay.
All right, cool. Well,
Kim wanted to know if you can send her the video too.
Yeah, absolutely.
She just wanted us to remind you.
Absolutely. You still haven't fixed that. I'll send you a 9-volt battery, so I don't have to hear you. I don't have to hear your fire alarm anymore.
Hey, I've tried and I can't take it off, but whatever. I'll tell my husband, see if he gets to it this time.
How do you sleep? If that's always chirping.
I swear I had never noticed it till you told me. I just locked it off.
Yeah, you just get used to it.
There it is again. I don't know how you can get used to that. I would want to run through a wall. I would have a broom and literally just knock that thing down.
It'll be like that episode of Friends with Phoebe and the fire alarm.
I'm telling you.
They did that on Station 19 too, where they were taking a broom and hitting it.
I would take a golf club, a wedge, a driver. I'd be slamming that thing. That's just not. That's not cool for me. I gotta.
I'll graduate in a few years and I can counsel you with your anger issues, okay?
that's something that would be in the realm of my control. So I don't know. I might go to Lowe's and order you a ladder. So anyway,
It's actually not really. It's like right there.
where is it? Oh yeah, I can see it.
I can touch it. I just can't take it out. I don't know how to do it. I've tried it, but
A YouTube instructional video for class tonight for Rafaela, so she can remove the 9-volt battery.
Normally twist it to take it
Right.
off. Twist it.
Safety.
Thanks, Matthew.
I did, and I just can't do it. I mean, if you guys, I will demonstrate if you guys want me to.
Twist and pull.
Bonus points.
Twist and pull.
Let's see it, Rafaela. Let's see. Okay, so we have some time while we're waiting on people to get to class. So let's see it, Rafaela. We're gonna fix Rafaela's smoke alarm.
Really?
Hold your camera up to. Or do you have a laptop or a phone?
I have my phone right now.
Okay, hold your phone up to it. I'm gonna make your screen so I can see it. Okay.
Oh
So-
no.
Yeah. Hold your phone up to it. I want to see. We're gonna fix Rafaela's smoke alarm. This has been since we started this. It's been a month, right? Okay, hold your phone up to it, and let's see what it looks like.
Hold on, I'm trying.
Okay.
How do I switch this thing?
Oh, you can
Oh.
just hold it up like that. That's cool. Okay,
See?
so yeah. So if you press down, that's how mine looks. So if you press down and go, you're gonna have to go to the left. You have to spin it to the left. Put it back on there and spin that cap to the left.
Great.
Do we click it?
It's-
Matthew, help us out.
How about I just hold on? Can you fix it, Louis?
I'm gonna find her real quick.
There's Matthew. All right.
There she is. So twist it, grab it and twist it. Just twist. Don't pull, twist and pull. Oh, look, it's off. Did you get it off?
Did it come off, Rafaela? Yay.
Yeah.
Is there a 9-volt battery in there? Oh, I can't hear you. You're on mute
Can't
now.
hear her.
Rafaela, you're on mute.
Mine are all hardwired into my electricity,
Yes. So are mine.
like hers was. But then
Yeah,
it
it's wired
has
into
a 9-volt.
electricity.
Okay. So did you take your 9-volt out?
It doesn't have a battery. It's connected to all those things. You want me to
Wire?
electrocute myself?
The wire should just unplug from the back.
Can you
It
unplug
could
the wire?
be, it could need to be
The wire's
cleaned.
on. There should be like a little clip pull.
It
It
might need
started
to be
blinking a
cleaned.
little bit more now.
It's a sign it's going to explode. So no,
The
yeah,
wire
if you
should
unplug
come
those
up.
wires, I think you should be able to take it down.
If I cut the wires?
Don't cut them. No.
it should just
Don't cut 'em.
Oh.
It should be-
unplug.
Okay, hold on. Let me try again. Hold on.
Should be like a little notch or something. You can just
You
like
can get
pinch it, come right out.
We need to get her a GoPro.
Yeah.
That's what my new classes are going to be. We're gonna send a GoPro around in the mail, and so when people have their presentations or they'll have demonstrations, we get to see your point of view. All right. Well, while she's doing that, I'm going to get our PowerPoints up and going. So we're getting close to the end here, gang. We only have what, 3 more weeks?
Yeah.
Yeah, we don't have much more to go. So let me share my screen while she's doing that, and we'll take a look at where we are. Okay, going into psychopharmacology, and let's pull up our syllabus. All right, so we.
Okay, here you go.
Did it?
Took it off.
How'd it go? How did it go, Rafaela?
I just couldn't. It's not a battery.
Okay, but you did take it off, so that
Yes.
will prevent it from going bleep, bleep.
Exactly.
It might need to be cleaned.
I mean, she
You don't
found the
have-
notch.
Now, so when your husband gets home, tell him, hey, I need to replace the battery in this, so he can take over for there. Yay, we did something. Thank you, Matthew. Thank you, everybody. We stopped Rafaela's beep.
It does have a battery.
Yay. Okay, so that needs to be changed.
How many college-educated people does it take to fix a fire alarm?
Look, Andrew, yes. All right, gang. So we did solve one of the world problems. I'm getting a lot of information and noise. So if you have like some kids playing, or I don't mind the kids playing, but you've got your headphones. Let's turn those up. Okay. So here we are. We're towards the end. We are at the 13th of April. So that means we have antidepressants tonight, which God knows we could all use some of those, given our situation. Next week, we've got cannabis, which y'all can argue.
Can all use some of that.
You could argue for or against that. And then on the 27th, I neglected alcohol. And so we'll come back and talk about alcohol, but we'll also have an exam review. So it's where you all will know what to expect for the final. And so the final, what I'm going to think about doing is just probably do something similar to the second exam, to where you all don't have to go anywhere. You can take it from, your own home, where you can probably take it once and, obviously study, because you do have that limited time frame. You don't want to just, be trying to find the answers on the fly. I guess you could, but, you would have another opportunity to go back and improve on your score. That helped, I think, nearly every single one of you. I think a couple of you had the same score, but by far and away that, and you do get to take the higher of your scores. If you happen to mess up and the second one's worse, you're not going to get penalized. So we'll probably do something very similar to that. And I'm probably also, I'll open it that night, that's a Monday. But I'll probably leave it open a couple of days, just in case something comes up for folks, or you want to take a little extra time to study. So probably the last date that you could take it would be like May the 5th, Cinco de Mayo. And you're not going to go out partying on Cinco de Mayo anyway, probably. But anyway, that'd probably be the last day you can
I'm
take
having the margarita party at my place.
Well, take the dang test the day before then, so you can enjoy your margarita party. So, okay.
Would it be possible for you to open it up like Sunday evening?
Yeah, I'm not gonna be. Again, it's gonna be up to you to kind of. It'll be timed. So once you start it, you have to finish it. So you just you got to find an hour or two block just to set aside to do it. So yeah, I'm okay with that. Just email me and I'll remember to release it a little bit early. Okay, so let's go ahead and look at antidepressants. So, before I get started, I've got probably people that want to present tonight. So who's presenting this evening? Raise your hand if you. Okay, so I've got Rachel. And anybody else on besides Rachel? I've got 2 screens of participants. And Rosa. Okay, so Rachel and Rosa, do you all want to go before or after I go?
I'll go after.
Okay, Rosa will go after.
I'd like to go before.
Okay, no, I'll just, it'll be a sandwich, so I'll be right in the middle. So, Rachel, what are you going to talk to us about tonight?
Antidepressants given to postpartum women.
Oh, okay, that's cool. I've never heard this topic, so
Interesting.
I'm interested to hear this. Okay, so let me adjust my setting because they always make it to where I have to allow participants to share. Hold on, because I know you can't share yet. It didn't used to do this. Okay, you should be able to share your screen now.
I made it.
Yay, Jenny, hi.
Took me forever. Sorry, something was wrong with the volume. I couldn't get it to work.
No worries. There you go. Rachel, your screen is coming through.
Perfect.
You have the
Okay.
floor.
So antidepressants used in the postpartum period. Okay. This is kind of the outline of what I'll be going over. Okay, so research says that 13 to 19% of women will experience perinatal depression, which is depression either during pregnancy or postpartum. And this can arise anytime during pregnancy or during the postpartum period. Hold on, I need to move these screens there in my way of the presentation.
And you can also, if you want to, you're welcome to take a little bit of time. You can take us through the outline of what you'll talk about too. I mean, that's
okay. Okay, so postpartum depression, because there is some people don't quite know what it is. They get it confused with some stuff with different different titles, and then how is it diagnosed as opposed to major depressive disorder. What drugs are prescribed specifically for pregnant and breastfeeding women, and what are the possible effects of that, and then what is the treatment plan. Perinatal depression can occur anytime during pregnancy or during the postpartum period. The women who are most at risk are ones who already were just predisposed to depression before they got pregnant, and just the increase in hormones and body changes, all that stuff just increases the likelihood of that. So they are most at risk. So what is postpartum depression? So one thing that it's mistaken for is the baby blues, and one thing that a lot of mothers get written off for is the baby blues, but the baby blues are acute and are a lot less severe, and it's a brief time of heightened emotions within the first few postpartum days and usually subsides within 10 days. And a lot of postpartum depression goes undiagnosed because it's written off as baby blues. But postpartum depression is a serious mental illness that can cause feelings of emptiness, sadness, anger, and can interfere with the mother's day-to-day lives and connection with their babies. The severity can range from anxiety and slight withdrawal from relationships to suicidal ideation or harming the baby. The onset can be right after the baby is delivered, up to a year after delivery. So the postpartum period is really big. And you know, someone can be doing great, and because your body, especially if you're breastfeeding, is still going through all these changes, it takes so for your body to completely heal itself and to be fully ready. Well, you can have a healthy pregnancy before this time, a second one, but for your body to be fully prepared to be completely restored, it's 18 months postpartum to have another baby. So that's, a lot of people choose to wait that long because that's when your body, everything's stored back up and ready to fully support another one. There are healthy pregnancies all the time that occur before that time, obviously, but that's when your body gets back to normal. So postpartum depression is diagnosed. It's according to the major depressive episode criteria in the DSM-5, and it has to include at least 2 weeks of persistent low mood or anhedonia, as well as at least 4 of the following: increased or decreased appetite, psychomotor agitation or retardation, feelings of worthlessness, sleep disturbance, low energy, low concentration, or suicidal ideation. So what drugs are prescribed? The drugs that are prescribed are typically ones that work on serotonin reuptake and norepinephrine reuptake. And the most common selective serotonin reuptake inhibitors are Celexa, Lexapro, Prozac, Serafem, Luvox, Zoloft, Paxil, and Vibrid. Then there's serotonin norepinephrine reuptake inhibitors, and those are Pristiq, Effexor, Remeron, and Cymbalta. And then there's also tricyclics, or tricyclics. These are serotonin and norepinephrine reuptake inhibitors, and they include norpramin, tofranil, Aventyl hydrochloride, and Pamelor. And then the others are Wellbutrin, Forvivo, and Aplenzin. So the effects of antidepressants on a developing fetus or breastfeeding child have not been well researched. Because of this, doctors typically don't recommend for pregnant or breastfeeding women to take antidepressants. The main reason a doctor would prescribe the antidepressant is if the risk is higher for the mother than the possible risk for the child. So I'm a birth doula, so I work with mothers kind of as a birth coach, and as a way to learn more, I listen to a birthing podcast called The Birth Hour. And so I've listened to some podcasts about mothers experiencing perinatal depression. And one mother put it as, I was afraid that I wasn't going to make it past my pregnancy. Her depression was so bad, and she experienced depression before, which made her more susceptible. And so her doctor felt comfortable putting her on an antidepressant to basically save her life, because she had an imbalance somewhere that required it. And so the risk of the mother was higher than the possible risk for the child. So what are the possible effects? During pregnancy, Celexa and Zoloft can cause maternal weight changes or premature birth. Paxil can possibly create a fetal heart defect. Wellbutrin, miscarriage or heart defects. Anafranil, fetal birth defects or heart defects. And for up to a month after birth, if a mother was on antidepressants during pregnancy, for up to a month after birth, the baby may experience jitters, irritability, poor feeding, and respiratory distress. And so that's why doctors are also very choosy on which antidepressants they give to the mother, and probably give them a low dose. While breastfeeding, the most common drugs to show adverse effects on breastfed babies are Prozac, Serafem, and Celexa. Prozac and Serafem can cause crying, irritability, decreased feeding, watery stools. Celexa can cause hypotonia, colic, decreased feeding, sleep difficulties. And just because these can have a negative effect doesn't mean they will. More research still needs to be conducted. So that's not saying that's going to happen for all of them, but these are ones that are possible. There's just not a ton of research. So what's the treatment plan? There are many causes of postpartum depression, ranging from hormonal imbalances to poor maternal support to obstetric complications. And because of this, there's no one way to treat postpartum depression. What works for one woman may not work for the next. Need more support. She doesn't have a supportive family or friends. And that's what's causing the postpartum depression. It's an antidepressant probably is not going to be helping her, because that's not what she needs. But someone with hormonal imbalances or something like that would probably need antidepressants. Someone with obstetric complications probably needs counseling rather than antidepressants or support. So people are different in what they need. So what antidepressants will do is to help balance neurotransmitters in the brain. They typically work on serotonin and norepinephrine reuptake. Hormone therapy, drastic drops in estrogen and progesterone at the time of delivery can cause the onset of postpartum depression. And this influxes throughout the postpartum period, which can cause the delayed onset of postpartum depression. Interpersonal therapy, this aims to help with role transition, role dispute, grief, and interpersonal deficits. So a lot of mothers struggle with going from being not a mother to a mother, or going from a wife to a wife and a mother. A lot of women that I know, especially ones that are breastfeeding, really struggle with the difference between their breast being sexualized and then all of a sudden being a source of food for their child. And so there's a lot of things that are kind of being hit at them, and how they're being needed all the time. And interpersonal deficits, so they are not able to have those interpersonal relationships as much. They don't have the free time. They don't have they don't have the freedom, since now they have a child that they're taking care of. Cognitive behavioral therapy, this aims to modify patterns of negative thinking and make behavioral changes while learning coping skills. Non-directive counseling, also known as person-centered, it aims to give empathetic and non-judgmental support and listening. And then peer and partner support, which builds on the idea that poor maternal support can lead to postpartum depression. It aims to create mother-to-mother support. I feel like no one understands a mother like another mother. And that's actually one thing that my capstone project is the effect of breastfeeding outcomes and maternal support on the prevalence of postpartum depression, which is why I chose this, because it just gave me an opportunity to read some more into this. So there's my references.
Cool. Right. So let's have, if you don't mind, let's ask Rachel some questions. What questions do you have?
Have you ever heard of someone being able to just call their gyno or anything and just say, hey, I think I have postpartum depression, and they just give them the medication?
No.
Because that's what happened with me. Like, they asked me some questions. Oh, sorry. They asked me some questions over the phone, and then they just called in the prescription.
Were you breastfeeding?
No.
Well then, so that was postpartum?
Yeah,
I mean, that's different. Because you weren't breastfeeding, I don't think that you should be able to just prescribe some, unless that's something that you were already on previously. So I don't know the ethics on that. But since you weren't breastfeeding, then that is not taken into account. So.
Well, thank you. You did really good.
Thanks.
Other questions? Rachel, you satisfied everyone's curiosity. Your scope was so comprehensive and treatment of the topic was so in-depth that you've covered every bit of ground there is to cover. I appreciate the topic. I will mention that briefly in our discussion tonight about safety, when during pregnancy, when breastfeeding. I thought you did an excellent job kind of laying out, difference between baby blues and postpartum depression. I enjoyed your, or at least you discussing how long it takes a woman's body to heal after pregnancy. So I really didn't know that everything kind of normalizes after a year and a half. I mean, it's quite a while.
Yeah, well, your body, your whole life has these like vitamin and mineral and all these stores within your body. It takes so much to support a pregnancy that those are depleted, and you're fine. But to support another one fully and give that, I don't know all the science behind it, obviously. I think it's something that really interests me. But yeah, 18 months is what it takes to build that back up fully.
Makes sense, since it takes you 9 months to give birth. 10. I mean,
Yeah, and then people typically breastfed for longer periods of time than they do now.
Yeah.
I mean,
Of, of this, the reading that I've done for my my research proposal. So it's recommended to exclusively breastfeed for 6 months and then to continue on breastfeeding for at least a year. So a year total. But you know, if you go on longer, that's great. There, you know, previous generation and long time ago, you know, people could breastfeed for 5-6 years because that was free and it was nutritious and it would supplement. It wouldn't be, you know, the only thing that they would consume. But now it's like, I forgot what the percentage of women that even make it to 6 months exclusive. And it's sad in the African American community, the percentage of women that breastfeed is almost non-existent. It's like less than 10%.
Huh. What to what do you attribute that the racial difference?
I don't, lack of communication, lack of education, to, because it's not just African, it's also low socioeconomic status. They aren't given the resources. It requires a ton of support to breastfeed, whether you're a stay-at-home mom or not, especially if you're not a stay-at-home mom. And a lot of these women can't afford to stay at home and take care of their children, and to pump or breastfeed exclusively. To do that, it requires a ton of support. Even women that have a lot of support, they can't. It's difficult for them. It's something that you need encouragement from people around you, and if you don't have that, then you're setting yourself up for failure. And that it wasn't whether or not someone breastfed that was a determining factor of postpartum depression. It was their expectation. So if they were planning on breastfeeding and couldn't, that was a sign of that they're predisposed to depression. And if they weren't planning on breastfeeding and they ended up breastfeeding, that's also an increased risk. So it's been really interesting reading about it.
That is really interesting. I'm glad that you spoke to some of the difficulties around child rearing, especially in, we don't have a society that, to me, values or puts a lot of value on mother-child bonding. There are some societies that, give, mothers a whole year off, to just to rear their child that first year. And some may be lucky to get 4 or 6 weeks. I think we have the Family Medical Leave Act where you get 6 weeks, but
6 weeks is nothing. Your body is not even close to being, especially if you had a completely natural birth, no tearing, no complications, no nothing, you might be okay. Your body, not your mind, just your body. Your mind is not ready. But if you had a C-section, if you had any kind of stitching that had to, any kind of complication, you're not ready.
Rachel, I have a question for you.
Yeah.
Since it's, you said lower income homes are less likely to breastfeed.
Uh-huh.
What is their alternative to pay for formula, even though they're less income?
WIC. I mean, it's crazy because formula is so expensive, and
yeah.
But the reason,
one of the big reasons, stuff like that.
Yeah, one of the big reasons that they don't breastfeed is they're not told. They know the benefits to the baby, but they don't know the incredible benefits to the mother as well, and not just the mother-baby bonding because it releases the oxytocin and creates the bond, but also it lowers their risks for cancer. It helps balance that. It helps get their body back to normal. The oxytocin causes the contractions of their uterus to get back to normal. I mean, there's a ton of health benefits for the mother as well as the child, and that's just not talked on as much. It's just like, yeah, it's good for the baby, but so is formula. So they're like, why if breastfeeding is really hard, and a lot of people think that it's not hard because it's natural, and so they come in with these expectations that, oh, this is natural, it's going to come to me naturally. But so many people struggle with breastfeeding, and then they get discouraged, and then they're done. And that really is hits hard for them, and then they're done and they're susceptible to depression after that.
What is
They
time?
said some women can't even use the pump. My wife couldn't.
Yeah.
She had to do breastfeeding.
And those are very
But
expensive. Those are very expensive devices too.
Insurance lets you borrow them. They'll let you borrow them because they want you to breastfeed. Well, based on your insurance, but most insurance sometimes do. Because I know with my first one, I tried and they didn't really push it. But my third one, and he's 4, they literally like did everything they could to make me breastfeed. Not make me, but to help me breastfeed.
Mm-hmm.
So.
Well, if the child gets used to the bottle, then it's harder for them to latch, and it's harder for them to, get used to.
And some people exclusively pump, and that's fine too. Whatever works for the mother. So yeah, there's a lot of learning in that area, that it's not, the information is not well distributed.
Yeah, I agree. I agree with that. And specifically, if you're under a lot of duress, you're under a lot of stress, trying to figure out, what you're going to do financially when you have a baby, who's going to support, daycare, having a job, making sure all of your regular roles are taken care of, house, whether it's house maintenance, cleaning, whatever it is. I mean, it's just overwhelming. McAndrew,
I had to do an essay for my deviant behavior class a while back that had to do with bias in our healthcare system, and even in small town clinics and stuff in socioeconomic communities, or in certain cultural, if you're African American versus if you're Caucasian, things like that. And I think that the data you just talked about, with the comparison with how many African American women breastfeed, really kind of goes along with that. It's
mother
sad that, even thinking about our small town, that some people in those diverse populations wouldn't feel comfortable, either aren't offered the resources as willingly, or don't feel comfortable enough to put themselves in a situation to get help to be able to do that.
The mother and infant mortality rate in African American women is like triple what it is in Caucasian. It's really bad. A lot of women are not taken seriously, and they are forced to do. Just look up informed consent in childbirth, and it could scare you. There's a lot of bad stuff that happens. And actually, in my class tomorrow, Abnormal Psych, my presentation is over PTSD after childbirth. It's real.
Very interesting, Rachel. I appreciate you speaking from a point of understanding. You did that during your PowerPoint, and it let me know that you really know your stuff. So rather than just reading the slides, your points, you're able to kind of go in depth and talk about what those meant. So I really appreciated that. So
something I'm passionate about.
Yeah, no, it's very good. Anything else for Rachel? Very interesting. Good job. Right. So that is an excellent segue for us to talk about antidepressants tonight. So that will be our topic. And if I can get this thing to display the right way. Here we go. So this is, I believe it's still chapter 12 in your text. Let's see here. It may be a different chapter now.
No, it is chapter 12.
It is chapter 12. Okay, sweet. All right, so I'll try to reference the book from time to time tonight. And also I'll kind of split time between our slideshow and the book. So we'll mention mood stabilizers briefly. I'm not going to spend a lot of time talking about mood stabilizers, although they are their own classification. of medicine. I spend a majority of our time talking about antidepressants. So we'll just kind of jump straight in. And Rachel did mention some of these in her presentation. There are several different kinds of antidepressants. And really, there are a couple of different kinds in the first generation. So when pharmaceutical companies and psychiatrists first started prescribing medications for depression, there were two different classes. And so these two different classes are known as MAOIs, which stands for monoamine oxidase inhibitors. And that can be found on page 445 to 447. But they also could prescribe tricyclic antidepressants, or TCAs. That's on page 447 to 449. The first batch, the MAOIs, the monoamine oxidase inhibitors, these included some substances like Nardil, Parnate, lutein. And if you want to turn there in your book, if you have your book, I'll flip over to 445, page 445. And what they found were, first of all, let's think about that. Let's think about the name, because the name kind of like SSRI. So if you remember way back when we actually met as a class, I broke down SSRI, selective serotonin reuptake inhibitor. And we knew even by the name of that, we could tell what it did in the brain. So we can do the same thing with the MAOIs, monoamine oxidase inhibitor. So first of all, what substances, so this is like a $32,000 question right off the bat. So what neurotransmitters are monoamines in the brain? Which ones are those? There's 5 of them.
Serotonin?
Serotonin is one. What's another one? Dopamine is another one. Very good.
GABA.
GABA.
Try
Yeah.
norepinephrine. Epinephrine. Anybody get the last one? Well,
Glutamate?
Adrenaline?
I don't think it's glutamate. I've stumped myself. I was hopeful that somebody was going to bail me out, and no one did. But that's okay. If we think of it, we'll come back to it. But if you think about those substances,
Is that the one that starts with an A?
I think so. But I'll thank you. But we'll come back to it. The main ones. What was it?
Amitriptyline.
Ambien, I think maybe.
No, it's okay. We'll come back to it. Let's think about these 3 primary ones. So serotonin, which is linked to what?
Mood.
Mood. Dopamine, which is linked to what?
Pleasure.
Movement and pleasure. And then norepinephrine, which is linked to what?
Like adrenaline?
Yeah, like energy. Nice. Man, y'all are killing it. Y'all are almost like just junior pharmacists almost. Okay, maybe not quite that good, but you're getting it. You understand these brain chemicals. That's way better than where we were in the beginning of the semester. So monoamine oxidase inhibitor. So if you have oxidation, what happens because think oxidase. If you have oxidation, I am hyping you up, absolutely. If you have oxidation, what happens when something gets oxidized?
It receives oxygen.
Faster.
What'd you say, Mark?
It fires faster. More transmitter faster.
If you have oxidation on something, it gets broken down.
It's removed.
Yeah, thank you,
removed.
Catherine.
Yeah.
Thank you. Catherine gets the $32,000 right there. Absolutely. If something gets oxidized, it gets removed. So this oxidase is actually an enzyme in the brain. So remember when I said, like, if you have too much dopamine and too much like serotonin floating around, what happens there's little things that come by and eat it, and those are the
Enzymes.
Yes, so oxidase is the enzyme that comes around and eats the dopamine, the norepinephrine, the serotonin. And so there's the monoamines, and then oxidase, and then inhibitor. So what is this drug doing? It's inhibiting what?
Keeping it from being took.
It's not reuptake. So but it's inhibiting it from what?
Breaking it down.
Bingo, that's it. It inhibits the little Pac-Man that's going through there and eating it. It inhibits the oxidase. It inhibits the enzyme. So the enzyme can't eat the extra neurotransmitter that's out there. So it makes dopamine work harder, norepinephrine work harder, serotonin work harder. So what would you think would be the result then in a human being in their mood?
Increased mood?
Yeah, these actually worked pretty well. They actually had a pretty good, as far as alleviating depressive symptoms, actually pretty effective. And really, we haven't found anything as far as just by virtue of alleviating depressive symptoms. We haven't really found anything that's that much better. Now, we have refined the drugs where they don't have as many side effects, but as far as just alleviating those depressive symptoms, yeah, these first two actually are pretty effective. And so you still find from time to time where they're used. They're not like some of the schizophrenic medication or some of the remember the barbiturates. They're very rarely used, but you still see some tricyclics and MAOIs, monoamine oxidase inhibitors, still used in treatment. So
they're great until you get serotonin syndrome from it.
Pardon?
I said they're great until you get serotonin syndrome from one of them. Absolutely. I got that, and it caused me to have an eye twitch. I still have issues with it today, and I've always taken, since I was 16, I've taken Zoloft. At 25, I switched and tried different ones, and then I've been on Cymbalta for 10 years. Well, I didn't feel it was working properly. And so my doctor said, well, let's try Prozac. Let's go up. Put me on Prozac. I was on it for 2 weeks, and I got this eye thing where I had to constantly raise my eyebrows or blink or anyway, she couldn't come to find out I was really, and I still suffer from it.
I'm sorry, you cut off at the end there, Haley, but you're absolutely right. I've worked with a lot of people, more than a handful, and kids too, not just adults. The more than a handful that I've worked with have been children. And so Haley talked about serotonin syndrome, and people can also develop what's a serotonin psychosis that goes along with too much. And so we'll talk about that later. It's very dangerous if your levels of serotonin are too high. And that's one of the, even with, like she talked about, one of the newer ones was Prozac. Prozac only works on serotonin, but you can have drug interactions. You can have food interactions. There are a lot of different things that you should pay attention to when a person is taking antidepressants. Let me turn on my overhead light. I'm starting to lose. There's not a whole lot of sunlight. Okay. So if we want to look at side effects for tricyclics, if you want to go to page 444, and we'll talk about tricyclics in just a minute. But does anybody want to take the second paragraph down there on page 444? It's actually the last paragraph on the page. And if you hit some big words, I'll help you out with them because there's a lot of big words in there.
I can do it.
All right. Thank you, Sarah.
Is it the one pharmacological effects?
It's 444, the last paragraph. The effects of TCAs on memory.
Ooh, okay.
I'll help you out with them.
Mine just looks different because I'm like on the internet one, so I'm like, it's confusing me.
Oh, you have
Hold
the digital book?
Yes.
Oh,
So I'm
okay.
kind of confused.
Yeah, I'll take it. It's okay.
Okay, I'm sorry.
So I'll just read it. The effects of tricyclics. So they're like MAOIs. They're the first generation antidepressants. The effects of tricyclics on memory and cognitive function are significant. The direct adverse effects on cognition are related to anticholinergic and antihistamine properties, which may be partly compensated for by the improvement in mood. Relatively non-sedating compounds with minimal anticholinergic side effects cause less impairment of psychomotor or memory functions. Therefore, because the young and the elderly may be more susceptible, patients of extreme ages, if treated with the tricyclics, should receive a drug with low potency at blocking histaminic and cholinergic receptors. So really be careful, basically what it's saying. You can have some pretty significant side effects. And on page 445, it mentions that cardiac effects of tricyclics can be life-threatening when an overdose is taken. So it's relatively safe as long as you stay within that therapeutic index. But if you take too much, the patient can exhibit excitement, delirium, and convulsions, followed by respiratory depression and coma. And so you can have cardiac arrhythmias, a lot of different things. So even though these things were initially pretty effective at alleviating depression, it's some pretty significant side effects. So, moving toward substances like Prozac, like Paxil, like Wellbutrin, they're not completely safe, but they're safer than some of these early ones. Let's go back into the PowerPoint. So here's some of the tricyclics, and I had the page numbers backwards here. No, I didn't. Yeah, I did. Sorry. Some of these include tofranil, Elavil, Norpamin, Aventil, and Remeron. Remeron was used quite a bit at Meadow Lake Hospital when I worked there. Do they still use Remeron up there, Rhonda?
Occasionally, yeah.
Occasionally. Okay. So you still see use of some of these sometimes. And then you have the second generation antidepressants. So these really this happened in about the 80s, 1980s or so. The first one was really Prozac, fluoxetine, which made pretty big impression back then. And so on page 451, you can kind of check out the side effects there. And so for instance, Prozac and some of the second generation selective serotonin reuptake inhibitors. So those are the ones that I really highlighted early on when I was trying to compare those with the stimulants. So on page 451, so let's look at those. It's right in the middle of the page. Anybody want to read those 4 and 5? Actually, there are 5 if you take the sentence after the 4 bullet points. Somebody read for just to get on my really good side tonight. Read the 4 bullet points and then the sentence under the 4 bullet points if you have the textbook.
So you want us to read like before discussing that part and then down below?
Yeah,
okay.
if you don't mind reading that, Rhonda, that'd be great.
Sure. Before discussing individuals' SSRIs, we address several concerns associated with SSRI therapy. The treatment-resistant patient, the serotonin syndrome, the SSRI discontinuation syndrome, the SSRI-induced sexual dysfunction. A 5th issue, the possible effects on the fetus if the mother takes the SSRI during pregnancy or while breastfeeding, is discussed in chapter 15.
Okay, so thank goodness, thank you, Rhonda. And so thank goodness that Rachel helped us out with the, problems with, because there are birth defects that can happen when someone is pregnant or breastfeeding and taking an SSRI. And I would postulate, and she went into the other antidepressants as well, also pose a significant risk. So the first issue there is the treatment resistant patient. So what would we be talking about when we're talking about a treatment resistant patient? Who is that? What do I mean?
People who don't want to take their medicines due to the side effects.
Yeah, sometimes. So you can have that, especially you see that a lot more with bipolar. So you see actually a much higher percentage of people who are compliant with their medication regimen on the antidepressants, because the side effects are there, but they're not as bad. Okay, so somebody like this might be somebody who I don't buy into all this psychology, stuff. I'll just get over it, or people that, and we have quite a few of those folks around these parts, this psychology mumbo jumbo. I can deal with it myself. Just pull yourself up by your bootstraps, get out there and make it better. So you also may encounter people who may have a lower ability to care for themselves and maybe wouldn't be responsible for taking medication for their daily doses. And so in those cases, it's important to think about, before you get somebody on a medication, because I'm going to jump to the third issue here, and the SSRI discontinuation syndrome. Anybody know what is the deal? Why is it dangerous just to stop an SSRI cold turkey? What's that, Catherine? Go ahead.
Well, it blocks the neurotransmitters, and so because of the effect that it has on the body, it actually causes an adverse reaction if you just stop taking the drug.
Absolutely. So here's kind of the thing with the antidepressants. So this, especially the SSRIs. So what's it called when you start taking a drug and you need more of the drug for it to have an effect?
Tolerance.
Very good, Renee. Very good, Sarah. So you kind of develop a somewhat of a tolerance to an SSRI. In other words, when you start taking it, your brain will try to down-regulate the amount of receptor sites and the amount of neurotransmitter that you have, because it's like, now I'm getting more serotonin and I don't think I want that much serotonin. So it starts to limit the number of receptor sites that can accept serotonin. So your doctor kind of, how long does it take really, and this is for, for those of you that have worked with antidepressants before, how long does it take before you can really tell what effect that antidepressant is having? Because it takes a while after you can't just take the dose and the next day, hey, I'm all better. How long does it usually
take like just 30 days?
So Alicia, you're right on the money. Generally, it takes about a month, about 4 weeks for your brain to kind of adjust to this new chemical, the new amount of serotonin that you're getting, because it's blocking that reuptake. Like Becky said earlier, with the SSRIs, like we learned the first week of class, it's just making the chemical stay out there longer, and it's not going back up into the axon to the sending to the sending neuron. And so your body adjusts to it. So it down regulates. And so after about a month, then you can kind of tell how you're going to operate on the SSRIs, because by then your brain's kind of balanced itself out. So back to what I just said about discontinuing. As Catherine said, your brain has now adjusted to, having this SSRI block the reuptake. So now when you suddenly remove that, what happens to the serotonin level?
It goes up.
It
No.
goes down. It plummets.
Oh.
It goes way down because now it's basically turning the vacuum back on, right? So
Oh,
now
yeah.
serotonin on there is getting zipped right back up, and there's not as many sites where serotonin can work. So people can get really suicidal if they drop and they get really, really down. So this is another class. Remember I said with benzos like Xanax, I said don't just go cold turkey. This is really another class of medication that people really shouldn't go cold turkey to quit. People really need to titrate that down over amount of time. And really, I would say that with any of these, the medications we're going to talk about tonight, I'd really kind of put a blanket statement out there. Don't just say, I'm good without my antidepressant. I'm going to go try to grind it out this week. Probably better to work with a doctor and kind of take that down gradually. Does that make sense? Okay. Okay, so let's go to another one. So I'm going through the bad side effects first. I might as well. Let's get them out of the way. So there are so on the discontinuation syndrome, if you want to see what all the side effects are, this is on page 453. And there are 6 that about way over half of patients, when they start to come off of SSRIs, start to feel this. So this is very common for people to feel these things. And this can last, again, up to about a month. It took about a month to get used to it in the brain. It takes about another month for the brain to adjust without it. And so anybody want to take us through the 6 things there on the bottom of page 453?
I'll do it.
Sweet. Thank you, Sarah.
Okay. 1, flu-like symptoms, which include fatigue, lethargy. I don't know that word.
Myalgias?
Myalgias, chills, headache. 2, insomnia, which includes sleep disturbances, vivid dreams. 3, nausea, which includes gastrointestinal symptoms, vomiting, diarrhea. Number 4, imbalance, which includes dizziness, vertigo, ataxia. And then 5, sensory disturbances, which includes sensation of electric shocks in the arms, legs, or head. And 6, hyperarousal, which includes anxiety or agitation.
Yeah. So, these are pretty powerful chemicals, even though it's just working on selective serotonin. These are pretty powerful chemicals that you're putting in your body, and it takes a while to readjust after these things happen. So I'm going to go up to the top of the page now, to top of page 453, where it talks about serotonin syndrome. And so Haley alluded to this, from her own experience. And I'll just kind of throw it out there with my own experience. I have seen this happen where a person has way too much serotonin. And, I'll kind of take you through some of the things that can happen. So this is about the 3rd or 4th line down. Accumulation of serotonin leads to a cluster of responses, including cognitive disturbances. In other words, your thoughts are disordered, maybe flight of ideas, maybe you can't have a good train of thought. Disorientation, you're just kind of feeling disconnected, don't really know where you are, fully. Confusion and hypomania, you can just feel flat. Behavioral agitation and restlessness. And I've seen this a lot, maybe repetitive movements and just constant movement. Autonomic nervous system dysfunction, such as fever, shivering, chills, sweating, diarrhea, hypertension, and tachycardia. And neuromuscular impairment, such as ataxia, increased reflexes, and myoclonus. Visual hallucinations. Interesting, huh? Visual hallucinations have been reported. Remember when we talk about serotonin and LSD and mushrooms? Some of these symptoms might result from excess serotonin at serotonin 5-HT receptors, which, and then it's going to talk to, which is the same site of action of psychedelic drug LSD. The syndrome can even occur when SSRIs are combined with herbal substances such as St. John's wort. We'll talk about St. John's wort later on tonight, or valerian. Once the SSRIs are discontinued, the syndrome usually resolves itself within 24 to 48 hours. But supportive treatment is needed because this actually can be fatal. So when I've encountered this more times than not, it's been in a combination. So Haley, your experience is one that I've heard before. I haven't worked with a lot of adults, but I've worked with a lot of kids. I've seen this in probably 6, 7, or 8 kids over the years where they're prescribed more than one med. I've seen this with Zoloft and I'll be flat honest, with an amphetamine salt for ADHD. So when I've seen more than a handful of kids prescribed an antidepressant and a drug for ADHD, think about what those 2 drugs are doing. Number one, if you're taking an ADHD med, what's it likely doing?
Eating you up.
It's keeping you up by working on the monoamines, right? Working on dopamine, right. Working on norepinephrine, maybe even some serotonin. When you take an SSRI, what is that doing?
It's selecting which ones and wants to accept and which ones it wants to leave in your system.
Specifically looking at the serotonin, and it's increasing the activity of the serotonin. So I've seen kids just kind of just be out of reality. I've seen kids that were normally functioning just in this hyper movement state and unable to focus, and it's really sad to see, and even hallucinations. And so people, well, maybe the kid doesn't have schizophrenia, the kid's got too much serotonin. Thankfully, I've seen every one of the children that have had this recover. But it is very scary for parents. It is very scary if you're the therapist working on this. So if you get a situation, and I'm throwing this out there because I've seen this a lot, honestly. If you get a situation where a kid is not themselves, or they're even responding to stimuli that aren't there. I had one kid that was talking to his dead father, and it just was he was out of his mind. If you have situations like this, consider what medications they're on, because they could have a serotonin psychosis or a serotonin syndrome happening, especially, like I said, with an antidepressant. And what I've seen is, I think it even happened with Strattera once. I think Strattera isn't like an amphetamine salt in and of itself, but it is an ADHD med. So just be aware. Just be aware in that supportive role, because a lot of people, you might be in a situation where something like that comes up. So anyway, I felt like that was important just because it's happened quite a few times, actually.
I've had 2 different brothers or stepbrothers get put on different ADHD or depression medications, and the effect that it has on them compared to what you would see, in my opinion, in an adult is pretty crazy. My first stepbrother that got put on it, they tried multiple medications with him, but what I'm seeing, at least in this part of the world where there's not a lot of actual mental health care professionals, is the pediatricians are just giving it to them and not actually making sure that that is what the diagnosis should be. And my little stepbrother, he had so many side effects to his. One made him physically lash out, one zombied him out, and then the next year all it turned out to be was when he went to the eye doctor, he couldn't see. He couldn't concentrate in school because he couldn't see it. And they got him glasses and the problem was fixed, but he had been on medication for a year.
Yeah, my son was on it also, and he was depressed before, but they gave him, I can't remember what it was, and we had to put him into, how do you call it? We had to admit him because it affected him so bad. depression, hallucinations.
Yeah, a lot of the medications are not really approved for use with children. I mean, in other words, when they did the studies, they didn't necessarily do studies with kids when they came out with the antidepressants, when they came out with the tricyclics. When they did the FDA approval process, it was with adults. And so, it's with kind of a grain of salt that people prescribe medications to children. And we are very reliant. I think there are over 25% of our children are on some sort of medication.
20%?
Psychotropic medication. Over 25% are on some sort of psychotropic medication. And so it's important that I will say this. I have seen, and I don't know if the doctor still operates this way at Meadow Lake Hospital, but I had a lot of respect because he tended to under-medicate, and also when children would come to the hospital, sometimes would take them completely off of all medications to allow just kind of a holiday to get a baseline for what's happening. Okay, what does this kid look like without any meds? And I think that's really important because like McAndrew mentioned, we don't have a lot of psychiatrists in Enid. We have one that is based here, and he generally works with adults, and he's booked, as far as I can see. I mean, so we do have sorry, go ahead.
Yeah, my son, he was in Alva and they didn't have any therapists there, and he just gave him the medication and it just sent him off to.
Well, and the doctors are trying to help. I mean, I don't take this way that I'm trying to badmouth pediatricians or anything, because pediatricians are trying to do the best they can. If you go to them and you just, I don't know what to do with my child, they're going to do the safest, best thing that they know what to do. What I'm just saying is that when things go wrong, consider these other possibilities. Don't just start out with a shotgun blast. Well, you don't know what you. No, that's not.
Question.
Please don't take what I'm saying that way.
So you say that like 25% of our kids are taking medication, right?
I think the last statistic I saw was
okay. So from that 25%, how many go on to having to take it like forever or till adulthood?
Good. Are you done with your research project this semester? Because I'd love to know that answer. Good question. I don't know.
What I'm saying is it easier to take the kids, like if you start them on meds, is it easy to wing them off, or are you going to have a struggle? Because I know, or I've known some adults that are taking medication, and when they try to leave, it's like a mission. So, I mean, I don't know.
Here's my thought with any giving a medication to any child. So you balance their needs to function in school, to function in their environment, with the needs of their development. So one of the things that we don't have a good handle on, I believe, is looking at long-term development. Because you don't have an experiment that's going to take 100 children over here for the control group and 100 children over here randomly assigned to the experimental group and give them a medication and see what happens to measure the differences, because that's honestly what it would take to really see what happens developmentally when somebody gets an amphetamine salt when they're 5, when somebody gets an antidepressant when they're 10, when somebody, we kind of have anecdotal, evidence based upon clinical trials. Well, they're not really clinical trials with kids. I mean, we basically have anecdotal evidence and trying to compare apples and oranges with kids that have had medications that haven't, but the kids that have had the medications have obviously experienced more dysfunction than kids that have. So it's hard to really know. It's hard to know what you're trying to.
Sorry, somebody wants attention.
Guys, mad. I'm not paying attention. So it's hard to really know what the thing is. And so what I try to really impress with parents is if they absolutely need it to function, yeah, let's go get a medication option. If we can find something that we can intervene before that, why not? Why not try? So anyway, that's I'm also coming from a place where my partner is an occupational therapist. And so she works a lot with children with sensory processing disorders, works a lot with children with autism. And so there are a lot of behavioral and different types of strategies that you can do to intervene that are going to make some of the same brain developmental changes that you want, that may be that you're trying to medicate for. And so there are a lot of different strategies that you can employ besides just jumping on with that ADHD med. I'm throwing it out there because we do, like you brought this up, Rafaela. Again, I mentioned it, but that over 25% of our kids are on a med.
I agree. I don't think that 25% really needs the medication. I don't know. I'm just weird, I guess.
I have a 7-year-old client that just got back from his psych eval, and they're recommending that he go on Abilify.
He's 7?
Mm-hmm.
Who did a psych eval? No, don't say that. Save that for our supervision. Don't say that here.
Yeah.
Less than so Abilify is for bipolar. Let me throw my 2 cents. This is where I'm gonna stop. Less than 0.5% of all people with bipolar are children. So let
Sorry,
that.
what was that? Because I was reading something. What was that?
This is an older stat. It may have changed, but as far as in 2005, the stat that I remember from then, less than 0.5% of all people with bipolar are children. So what I'm saying is be careful with Abilify. I'm not saying yes, no, or the other. I'm just saying that if you're going to use a bipolar med, I sure hope that's the lowest possible intervention that we can have. So anyway, that's what I'll leave it there. Let's move on. So on page 454, this is the last kind of side effect I'll discuss for the SSRIs, selective serotonin reuptake inhibitors. This is the Prozac, Paxil, Zolofts. Sexual dysfunction is often associated with major depressive disorder. If you're depressed, I don't really feel like doing it. I don't want to have sex. So, an SSRI medication can further compound it. So this is from a 2009 study. Up to 80% of depressed patients treated with SSRIs exhibit sexual dysfunction, including problems with orgasm, erection, sexual interest, desire, libido, and psychological arousal. In males, ejaculatory dysfunction seems most prominent. Loss of desire and sexual dysfunction can affect medication compliance and impair interpersonal relationships. So it can affect people intimately. Treatment of sexual dysfunction can involve discontinuation of the med, switching to an antidepressant in another class. So Viagra and Cialis have been found useful for some patients, including females. Furthermore, it may be the case that with the successful treatment of underlying depression, these antidepressants, the impairment in sexual function, will coincidentally improve. The main impairment I've heard from patients is that they can't achieve climax. It's like they can't, they can have sex, but it's like, you go for a while, okay, I'm kind of done here. It's like, that's enough. So just FYI, that's another very, very, in fact, up to 80% of patients report something like that, which.
Cymbalta actually has the least amount of sexual side effect out of all the drugs, which is, I get that because I experienced that myself. On top of, having have had a complete hysterectomy 14 years ago, on top of all that, then you go with your medication and you're just like, what's the point? Life sucks.
Right. Right. It does kind of, for a lot of people, it just removes interest. It's just like, I'm not really interested in that. And so obviously that can impair,
You learn a lot more things there is in life.
Pardon?
Better relationships built off of, said you learn better things about relationships because they're not based solely off sex anymore. It's you've got to really like the person.
Right? There better be something
You
else.
call those roommates.
Better be something else going on.
He doesn't think it's so fun.
For men, sorry,
What'd
go
she
ahead.
say? What did she say? I couldn't hear her.
Oh, I said he doesn't think it's so fun, but at least I'm a good cook.
Right on. Hey, you know what? A good meal is just as much dopamine as, well, maybe not quite as much, but you're still getting that dopamine from a good meal. You go
It feels way to the heart, through the stomach.
Right. Absolutely.
So when I did my volunteer hours at the Northwest Domestic Crisis Center, this lady actually talked about this research that she had read or something that talked about the importance of high-calorie meals in people that have experienced trauma.
I would concur with that. If you experience trauma and you've got that low dopamine and you've got low serotonin levels, you have a nice meal. There's I want ice cream from Rafaela. I want a nice, thick, juicy, medium rare, maybe even rare ribeye. I haven't had one of those in so long. It's making my mouth water right now.
Yeah, you need to stop because now I want to go to Vegas for the $5.99 steak and eggs at like 4 a.m.
But it's comfort food. There's something to comfort food because it gives you the endorphins. So anyway, let's jump back into our last thing I'll say about the sexual side effects. For some men that have the premature, they can't hold it. That might be good for them. They might need something that's going to take the edge off. And so there you go. Anyway, last thing I'll say there. All right. Third generation antidepressants. There are a lot of antidepressants. We prescribe these a lot in this country. And these are called atypicals. And atypicals, they don't just work on serotonin. They work on serotonin and norepinephrine. So again, this will be a test question. Serotonin is involved in mood. What's norepinephrine involved in?
Energy.
So you're getting kind of a double-edged, not quite
Repeat, I'm writing it down, please.
So it's not quite the tricyclic or the MAOI where you're affecting all the monoamine oxidase, where you're not affecting all the monoamines here. So you're just affecting two of them, serotonin and norepinephrine, that have to do with mood. Norepinephrine has to do with energy. So like it says here, both of these are monoamines. They're designed. So this is really for people when they come in and I'm depressed and I can't get off the couch. I can't go to work. I don't want to leave the house. I just want to sit. And so this can help, treat symptoms of fatigue and loss of energy. And so lining up directly with what Rachel reported were SNRIs. Thank you for being accurate in your presentation. These include Effexor, Wellbutrin, Cymbalta, Prestige. Third generation includes a variety of chemicals that do many of the same kind of things with various compounds. So there's some other drugs, Deseril, Ascendin, Zyban. So then we're going into, let's jump into mood stabilizers for just a second. So mood stabilizers, now we're moving away from serotonin, okay? So our first generation mood stabilizer was really lithium. And so Nirvana had a song called Lithium way back in the day. And so lithium had a lot of real troublesome side effects. Some of the other meds originally used to treat seizure disorder, epilepsy were found in treating bipolar disorder without some of the side effects. Some of these were Tegretol, valproic acid, or Depakote. Is that still used in, I mean, like I remember we used to use Depakote quite a bit, Rhonda. They still use that with kids?
Yes.
Yeah.
Yeah.
So VPA, you got to take blood levels with that one because it can build up in the bloodstream and be, and so you got to titrate your dose and then also take a blood sample to make sure you're not overwhelming somebody with VPA or Depakote. Lamictal is also another one to kind of level the mood out, but they can also be used to treat like epilepsy and seizures. Lithium's pretty hardcore. It does have some negative side effects. You saw really poor med compliance, really zaps people. And so folks that were bipolar and they're used to being manic and you know, up, they didn't like taking it at all. And you still see that with these, even these other ones, you still see poor med compliance. I'd say that with any of the disorders, you probably see the lowest compliance rates of folks that are dealing with manic symptoms and bipolar, just because you feel pretty good when you're manic. And when you take these meds, you don't really feel like it.
What is the most common medicine, like specific medicine you would say for bipolar? Or bipolar 2 specifically, if we were being more specific?
I'd say what Becky mentioned, you do see a lot of Abilify used these days. It back 10 years ago, 20 years ago, that would have been a different answer. But I think that the field has kind of gravitated toward that third generation bipolar med, which is Abilify. And would you agree? Do they use more Abilify, or do they tend to use the older stuff at Medlake now, Rhonda? I know with adults, I think they've really trended towards Abilify.
They do use more Abilify. And going back to the Depakote and the Lamictal, I know Dr. Philman does use a lot more Lamictal than he does Depakote anymore.
Okay. Yeah, Depakote, it's more dangerous because you got to monitor levels always. So, okay, thank you. Does that help, McAndrew?
Mm-hmm.
Okay. So we did talk about this, MAOIs, so monoamine oxidase inhibitors. So degrades monoamine molecules, the oxidase, and so it's the enzyme. So you're taking that enzyme away. So you have prolonged duration on the postsynaptic cell. It stays in the synapse longer. Too much can cause liver damage. So you got to be careful on the MAOIs. Tricyclics are named this because of their 3-ring structure. So there they are. They act as anticholinergics. And so this has, if we're talking more about like nicotine works on some of these receptor sites, blocking acetylcholine. And that is our 5th monoamine. Now, somebody said it started with an A. Acetylcholine is our 5th monoamine. So we got there finally. I remembered it, but it took this to jog my mind. They antagonize histamine and adrenergic receptors. And so if you've got too much histamine and adrenaline, that can have some unpleasant side effects. The tricyclics. We discussed those a little earlier. So here's the 2nd and 3rd generation. SSRIs have minimal side effects because they don't affect the other monoamines as much. SNRIs, as I said, blocks reuptake of serotonin and norepinephrine, giving you mood increase and energy increases. Mirtazapine acts by antagonizing autoreceptors to prevent inhibitory feedback to the cell. So that can induce sedation and drowsiness. I'm trying to think of the brand name for this one. Dang it. I'll come back to it. I'll remember it in a minute. So 1st generation versus 2nd generation effectiveness. Like I said before, the 1st generation are generally just as effective with depression. And so if everything else fails, like, I had, a really bad reaction on Prozac. Effexor, I didn't tolerate well. It may be okay to go back and try one of these 1st generation antidepressants just be aware they have some significant side effects. There are foods that interact with the MAOI. So I think there's some place you got to really watch, like drinking like orange juice, like eating grapefruit. Some of these things can really, eating, I think too much broccoli too, can really kind of interfere with the way these are handled in your brain. So, and I think I've got a handout that talks about that. So I'll come back to that. So it says, be careful eating aged cheese, beer, wine. Watch out for the pickled herring. I know everybody's just down in the pickled herring left and right these days, and chocolate. Okay, so here's how these are absorbed. The tricyclics and MAOIs work really quickly. They peak in 1 to 3 hours. And so SSRIs are absorbed more slowly. Most are actually destroyed in the digestive tract or liver. So remember that first pass metabolism, when you're taking something orally, your stomach gets rid of it. Alcohol interferes with the first pass metabolism, so they can be absorbed at too high of levels, resulting in severe overdose. So if you're on an MAOI or a TCA, don't drink alcohol with your pills. It's a bad thing. So alcohol doesn't really affect absorption for the SSRIs, the Prozacs, the Paxils. So this isn't really an issue. Excretion. MAOIs, as I said, they come on board fast and they have a short half-life. They come and go pretty quickly. TCAs is quite a bit longer, about 24 hours to get rid of the tricyclics. Second generations, SSRIs have a shorter half-life than tricyclics and require more frequent dosing. The newer SSRIs have a short to medium half-life, and so they can reach a steady blood level in a few days. However, Prozac has an extremely long half-life. It's about 16 days. It may take 75 days for Prozac to reach a steady state in the bloodstream. And it may take this long to get out of your system after you stop taking it. And it really depends on your metabolism too, and your genetic makeup. Okay, so you can have some pretty bad side effects with the TCAs. Irregular heartbeat, blurred vision, ringing in ears. You retain your urine, can't pee, excessive sweating. Older patients may tend to have confusion and delirium. Almost 50% of people in people over age 70. So be careful. You probably don't need to put them on tricyclics. SSRIs, you can experience nausea, headaches, nervousness, kind of feeling keyed up or on edge. Again, look at this one down here. Reduce REM sleep. Sleep deprivation. I already talked about the sex problems. Here we go with Rachel's presentation. Women are twice as likely to miscarry on both TCAs and SSRIs. So it's a big risk. Again, like she said, the doctor really needs to, there better be something really significant with the mom to keep taking the medication. Black box warning for adolescents and children tends to double the suicide risk. So same thing, if you can get by with something else, try it. And here's the serotonin syndrome, psychoses. It's pretty common, taken with other serotonergic drugs such as cocaine or amphetamines, or other antidepressants too. So it's best to allow basically a holiday or a washout time when switching from one antidepressant to another, especially Prozac, because again, Prozac stays in the system for a long time. Not used that much anymore. Some other effects, tricyclics tend to cause weight gain, about 1 to 3 pounds a month. Another reason why people stop taking them. Lithium also causes weight gain. MAOIs do as well. SSRIs tend to cause a weight loss. So people sometimes don't have an appetite when they're taking like Paxil, these other drugs, SSRIs. MAOIs interact with many other drugs and can cause liver damage. Let's see here. Yeah, so I'll mention this quote. Kind of covered these things already. Really, there were a lot of, when Prozac first came out, there was kind of a reaction because people that were taking it kind of had this switch in their personality. In other words, people that used to be kind of shy in public would all of a sudden kind of be the life of the party and kind of outgoing. And so people were really concerned about like even the ethics of taking this drug. It was like, is this fundamentally changing who people are by taking Prozac? It's, you know, that picture with the lady taking her head off. So there were some real ethical, when it was first prescribed, questions, because it's like, is this making this person into somebody different who they really aren't? So I don't know. I mean, that's something to consider. I think still, because some people, when you talk to folks that have taken a lot of the SSRIs, it does give you a head change. You do have most people kind of have a shift in perspective and behavior.
I have a friend who just started on Cymbalta 2 weeks ago, and she's going through a really hard time with all the side effects right now. Mainly like the nausea and sleeping and stuff like that, but.
Yeah, so Cymbalta's got the energy, the norepinephrine and the serotonin. People just kind of feel out of their head. They don't feel right, feel anxious and keyed up, and maybe even kind of paranoid at times. So yeah, I would say if she's on board with the doctor, keep it up and see where she's at in a month.
She's only having to take it for a period of time because it's actually for issues with her back, and because of everything going on, she's actually supposed to have injections in her back, but she can't go to the doctor because of COVID-19 right now to get the injections, so they just shoved her on that for right now, and yeah, it's not going well.
Ooh. Yeah, I don't have anything for that. maybe a telemed session if they can accommodate that. So I saw a recommendation to take at bedtime. I'm going to say probably no, because if you get serotonin and norepinephrine at bedtime, it's going to impair your sleep more. I would, let's see, what's the one? I was trying to think of this earlier. It's not Lamictal. It's not Remeron. Golly, there's one out there that it actually is better for sleep, but that's not it. Cymbalta, if I understand Cymbalta correctly, is going to activate someone, so that might not be the best thing to take it at bedtime. Okay, so there are many uses for antidepressants. It has been effective, especially Zoloft, in treating, and Wellbutrin in treating OCD, alcohol treatment, weight loss and eating disorders, depression. I have no idea. I think maybe the depression in parentheses there is like maybe not quite clinical levels of depression. So maybe it's not quite feeling right. And everything in between that looks like depression. Anyway. Efficacy. Efficacy rates are similar for all classes, doesn't matter. Severity of depression may affect efficacy rates though. This is probably my most important slide for me, because when I read and when I initially taught this class, this stood out to me the most. It was like, wow. And I took some things from another textbook, and I'll share those in just a minute. So when you do an experiment, if you're going to do a true experiment, what's very important? And I talked about this, with treating kids. In fact, let's take, because I know people are kind of ready for a breath. Let's take 5 minutes. I'm going to jump back in this slide. I need something to drink. Go take a bathroom break. Get a breather. We'll come back and we'll get into this.
I apologized for a while ago. I just didn't want to forget to bring it up.
What's that?
My client.
Oh, you gonna be in class Thursday?
Uh-huh.
Let's bring him back up Thursday.
Yeah.
I won't be there Thursday. I want to know.
Well, as soon as you get into practicum and you're out practicing with clients, then we can talk. There's a bit of confidentiality we need to maintain. So,
But I'll be there in like 2 months.
right on.
Yay, Alicia! Then I could do my practicum with you.
No, you have to wait till your last 2 semesters.
I know, but you'll be practicing already. So I'm
That
gonna
is true.
I'm gonna go work with you.
Let's do it.
All right. Well, I'll go ahead and start back, and people can join. So let me share my screen. So I found the old textbook I used before this one, and so this relates directly to our discussion tonight with the antidepressants. And so this comes from Prozac was on the cover of Newsweek. The psychiatrist is extolling its benefits. So Peter Kramer said Prozac seemed to give social confidence to the habitually timid, to make the sensitive brash, and to lend the introvert the social skills of a salesperson now you'd say these days. But Kramer quoted one of his patients as saying the drug made him feel better than well. He also coined the term cosmetic pharmacology, psychopharmacology, because they change some of the aspects of their personality. Let's go to the next.
I feel like that glamorizes medication and would make it like anyone should take it.
Yeah, it's almost like if you got a little trouble with social anxiety, let's try a little Zoloft here and see what that turns out like. No, we are a society that looks for a magic pill. I will concur with that. So this is the next page in that book, in that same textbook. The presence of a comorbid disorder such as anxiety is an additional important consideration, since some newer antidepressants, like the SSRIs and SNRIs, are also used to treat other psychiatric conditions. There are also considerable differences in severity of side effects in different individuals. So basically what that's saying is what may work for one person may not work at all for another person, because we are genetically different and our brains have different structures. Even though we're similar, when we take different chemicals, some people are happy drunks, some people are angry drunks. I mean, we just react differently to different chemicals.
Is that some of them are lower in serotonin or lower in dopamine, higher in one or the other?
Well, and Becky, we have, we talked about brain anatomy, neural anatomy early on. And so we have the basic structures. We all have a cerebral cortex. We have a frontal lobe. We all have cerebellum. We all have corpus callosum. We all have amygdala. We all have hippocampus, all those good structures. But within that, we each have our own variants, because I've met people that are similar, but I've never met two people that are exactly alike, personality-wise, physicality-wise. And so when all those things are together and manifesting, maybe some people have more serotonin in this area of their brain, so it makes them more on edge when they get more serotonin. Maybe some people get more so, maybe somebody that's not socially prone Now they take an SSRI, so now it makes them outgoing. It just has different effects on different people. I'll speak to my own experience. I took an SSRI for a month, and this is a long time ago. This is probably this is over 20 years ago. I didn't really care for how it made me feel. I mean, some of the things that it talks about with kind of making you not feel like yourself. I've definitely experienced that. I said a few things that I later regretted. I was like, why did I even say that to that person? That was just mean. It wasn't trying to be mean at the time, but then I was thinking, golly, that's so insensitive to say that to somebody. This is horrible to share. I kind of made fun of, well, I did make fun of a person's shoes who I'm pretty sure had an intellectual disability. I mean, that's not me. I didn't have a counselor, for God's sake. I mean, it was like, it wasn't, I don't know. They didn't do well with me. And so other folks, I have another therapist who I've supervised for a long time, and she swears by them. I mean, she's like, I can't make it without my antidepressant. They literally saved my life, and I will continue to take them. And so if this works and it goes and people benefit, please don't take the way that I teach this class to say that nobody should ever take a medicine. I don't take that. That's not what I'm saying. But I am saying that if you can make it without taking one, medications have a lot of different side effects, as we've come to find out over the course of this semester. So sorry, go ahead.
Sorry. So you're just saying that like our brain structures are similar, but our chemistry and like the way it'll react with the drugs, chemicals and stuff?
Yeah, that's different. That's individualized. Everybody's their own individual. And so when you take a substance, you don't really know what it's going to do until you take it. Now you can look at the studies on 1,000 different individuals and kind of get a bearing on what it might do. But you really don't know until you ingest that substance. That makes sense?
Those drugs have a way of affecting your naturally functioning of your body. So when you're substituting that drug inside of your body, it's learning how to rely on that drug. And you're handicap your body to rely on something that it's healthier for you to learn not to rely on it. And I agree with the instructor. Sometimes those types of drugs are needed to get us through periods where maybe we're struggling, but long-term effects, it has adverse effects on your body with continued use. And I did take Zoloft in my early 20s, and a month of it was all I could stand because it made me feel awful. I felt like a zombie and felt jittery, nervous, all those symptoms that had been mentioned earlier. So
I appreciate you talking, Catherine. I won't go quite as far as what you said there and say that people should, because I'm going to differentiate and say that some folks, like for instance, I'm going to qualify. Some folks, like my therapist friend, I supervised her for a long time, and I also worked with her for a long time as a colleague. Wonderful person. She'll continue to her own testimony. She'll continue to take that antidepressant till she's dead, because it helps her from getting to that point where she can't make it. She struggled with depression, and I've heard her story. She struggled with depression for many, many, many years, and suicidality. And she really attributes her being here on this planet to having the medication. So, I mean, I see you kind of smiling and smirking about that story, and I don't take it as a smirk or a smile, or to like discount her experience, because I truly, genuinely believe what she's telling. So I think it's very important for us to to acknowledge that some folks really can benefit from long-term medication. I'm just saying that if you can refrain from it and find different ways, it's worth looking into. Does that help? So in
Yes.
other words, I'm kind of deviating from Catherine, because Catherine was like, the way I took her statement was like, no meds if you can help it. And
I took Prozac for 2 years in my mid-20s. I was suicidal. I attempted suicide twice before I decided it was time to get help. I wouldn't be here today if it wasn't for Prozac.
I appreciate that, Leanne. And I mean, I've worked with patients, I've worked with clients who have told me the exact same thing. And it's just like, I need this to keep going. And even though, you don't take it now, it's really an individualized thing. And please know that each one of you have your own individualized worldview, but so does everybody else.
Right.
I kind of think that it adjusted everything in my system for the 2 years I took it. Because since I've been off of it, I haven't been, I still get depressed, but not suicidal and, out of control depressed.
That's something common. I've heard people as well who've come off of antidepressants, whatever changed, something changed. And now I no longer go here, but I go here and I function better. If I'm hearing you right, that's kind of what you're saying.
Yeah. I mean, like I said, I think it, I can't say fixed whatever was wrong with me, but I think I don't know, maybe it got me to where I could get a control of it. But it fixed something.
And I would say that you are making different connections in the brain when you're ingesting a psychopharmacological substance. When you're taking medication, there are changes in the brain. And if there are some new synapses in there that keep somebody from getting as depressed, or maybe develop some people may get a new way of coping, because now I look at the world a little differently. I didn't look at the world quite this way, and now I see it in a little different perspective. So
right.
I'm good with that. I'm good with keeping people here. That's what, hopefully at the end of the day, when you're dealing with psychology, if you can keep people on this side of the grass where all of us are right now, that's where
kind of your job.
Right. That's kind of what we're supposed to do. So I'm okay with that. So anyway, good talk. I will say this though, and I'm glad we had that talk now, because you'll be able to take what I'm going to say in a different way. We are not yet at the point where we can say that antidepressants are a cure-all for all depression. Approximately 60 to 70% of individuals with major depression get some relief from antidepressant medication. But only 28 to 50% show full remission of symptoms. Now, what I will say with this, with 60 to 70% of individuals, if you put antidepressants up against cardiovascular exercise, 3 times a week, 30 minutes a day, up against cognitive behavioral therapy, which is you're working with your own thoughts and your own beliefs and going to therapy. If you put the medication up against the exercise, up against just the therapy, which is better?
The cognitive exercise and that stuff?
They all have very similar rates of efficacy. It's negligible, the difference between them. So they're all about the same. Now, you have people that can exercise. You've had people that tried to exercise. You have people with physical, ailments that they can't do that. You may have people that, I don't want to go to cognitive behavioral therapy. I don't want to see a counselor. I don't want to see a therapist. And so you do what you can. You do what you can with what you have. This was what stood out to me when I read this textbook. Much of the improvement associated with antidepressant treatment is evident in patients treated with placebos. Placebo response rates are as high as 30%, which compared to 50% response rate in drug-treated individuals means that the mere expectation of improvement can account for up to 75% of the improvement that actually occurs. That's from a 2011 study. So in other words, when you go to do an experiment on whether a drug works or not, some people get a sugar pill, some people get the Paxil, some people get the SSRI. And so by virtue, so, you know, you've heard these probably not recently, but the commercials, are you depressed? Are you experiencing bipolar? Contact so-and-so for this experimental study, you know, sign up, you know, we'll monitor you, you know, you get benefits. And people typically do get pretty good benefits in these studies. They get, you know, a full physical, a physical exam, they get psychologically, you know, all these tests administered, and they have to give you the results. That's ethically, you know, required. So you get a lot of extras when you actually volunteer for these, whether you get the sugar pill or the treatment. But what they found is in these trials that 30% of people in the experimental group get better anyway, because what they're taking is the sugar pill. They think, hey, this is going to help me. I feel better. I know this is the real pill. I know I'm not in the experimental group. I know they told me I had a 50-50 shot of not getting it, but I feel better. I know this is the real pill. And a lot of people get better anyway. Placebo effect rates have also grown across the past few decades. With millions of individuals having taken antidepressants, there's a growing belief that they work. So the expectancy that there will be improvement is increasing. And so we go over to this page, one more. Our belief in the effectiveness of antidepressants over placebos is also influenced by the way in which research is published. So let's say we did a trial about I don't know, I started eating my cat's cat food. I'm just trying to think of anything that's, but I haven't, and that's improved my mood. So I'm going to give some people the placebo that's not my cat's cat food, and other people are going to get cat food. Well, I published, you know what? I didn't find a difference, right? Because cat food is cat food. It's not going to make somebody feel better. But other people have tried medication concoctions, and they didn't have an effect. So these studies didn't get published, right? But people have gone in and looked at these studies that didn't get published and found that even if you consider this unpublished data, that the placebo effect can account for up to 82% of the effectiveness of antidepressant medication. Just because in these other studies, people are taking the crappy medication that didn't work and the placebo, and they're getting better regardless because they expect it to work. Furthermore, in patients experiencing mild or moderate depression, placebos were no more effective than the antidepressants. Only in the most extremely depressed patients was there a relatively small difference in the outcome between the placebo and drug groups. What do y'all think? My therapist friends hate it, just hates it that I teach that. She honestly just cringes. Placebos. Okay. Withdrawal. Tricyclics, you can have a withdrawal from tricyclics. Anxiety, chills, muscle aches, akathisia, not anxiety, but restlessness, feeling of a need to move. SSRIs, you can have dizziness, fatigue, anxiety. This can last 3 weeks. Again, so you need to titrate it off. I took these from our textbook. We've already gone over those. So guidelines for going off the medication. So typically, you know, it takes about a month to figure out, okay, is this working or not? But if you've taken it for a long time, you kind of need to go off of a period of 4 to 6 weeks while watching for depressive symptoms. The person would want to be educated to be alert for any symptoms such as poor sleep, fatigue, etc., you know, suicidal ideation. Contact the doctor. If there was a second episode without risk factors, you know, gradually discontinue the meds as above. If there are risk factors, more recent severe episode, people that are suicidal, you might need to stay on these for a while. Medication evaluation. So if you have sustained symptoms rather than occasional symptoms, so if somebody's got occasional depressive symptoms, I'm going to really try to focus in on therapy or exercise or yoga or something different besides medication. If depression comes and goes, I'm really going to recommend something else. If psychotherapy is not working or they have a really severe level of depression, as we noted before, medications can work. We want to stay on this side of the grass. People are poor candidates for therapy if they have a low IQ, they're maybe not psychologically minded, or maybe they've refused therapy before. They may do better with medication. We kind of talked about these folks before. This is important concept. So if we're using these to treat depression, depression really comes in waves. You know what, I probably should, I'll do this next class. Depression is very cyclical. In other words, we can have times when people that are maybe chronically depressed, clinically depressed, when they function okay. You know what, I feel all right this week. I feel okay. But then they have those 2 weeks just down, I don't feel good. I'm not up. I just don't want to be here anymore. That's disconcerting. I mean, that's a bad thing. And so when people take medications and let's say they maybe have what I wouldn't call it a relapse, because it's not like they're using a substance, they're becoming depressed, but they're cycling back into a bad state. Should they take medications again? Should they try therapy? I mean, it all just depends. It all just depends on the individual, how they've tolerated the medication, where they are in their life. There's a lot of factors to consider.
I think not just specifically to antidepressants, but a major factor is what exactly they're treating. Because, depression is probably a whole different ballgame compared to treating bipolar. Because, if you're bipolar and are trying to get your meds lined out, you're one lucky dude if you get it straightened out in even 90 days.
Yeah, I agree with that. Yeah, it really depends on the presentation of symptoms too, like you said. Good point. And my cat is deciding it's about time for class to end. Hang in there, Eli. We're in the home stretch. He can't hear me at all. All right. But remember, 50 to 65% of people will experience either chronic or recurrent episodes of depression. All right. So that's why I mentioned this, is you generally are going to have cycles where people are better and worse. There are other effective treatments, and I've given you all some. So as I mentioned before, looking at cognitive therapy, cognitive behavioral therapy, really a good choice for depression. A good, if you're interested, the Beck Institute, Aaron Beck, Dr. Beck made the Beck Depression Inventory, the BDI. That's kind of the gold standard to determine whether somebody is actually depressed or not. A good resource is the Beck Institute. His daughter, he's passed away, but his daughter's kind of carried on his legacy as far as cognitive therapy, working with irrational thoughts and beliefs. It's really effective for depression and anxiety. If you have somebody that's got depression or anxiety, I would say, and go into counseling, find somebody that's a good cognitive behavioral therapist. If they're good at their craft, they can help you kind of rewire, make some new connections in your brain, give you a different outlook. Exercise, and I didn't mention strength building, but actually a good mix of cardiovascular exercise and strength building increases endorphins, natural serotonin levels in the brain. For those people that suffer from low T, that's all we have nowadays. You suffer from low testosterone, you need to come to the men's clinic. No. You know what? If you do exercise and you do weightlifting, your body naturally releases more testosterone and you become healthier and you become less depressed. So again, when you have these people pushing all these, medications, all these different cures at you, there are things you can do to, affect and change these things behaviorally. So cardiovascular and strength training, good for a lot of things. Mindfulness, how many of y'all, I know a couple of you journaled about this. Who did the breathing exercise where you kind of counted and you're trying to figure out?
I did it.
All right, cool. Well, a couple people did that. So that's kind of a mindful exercise. It's more of a Zen exercise because you're trying to stay focused on the same thing. But anyway, meditation is good. Yoga as a complementary treatment has been shown to be really effective. We talked about that releases serotonin. It releases GABA when you're done, when you're finished, when you're in Shavasana, when you're laying there and just soaking up all that work that you did. You're getting good chemicals released in your brain. It's like your recovery is happening. And I will say this. Other effective treatments for depression, they've found that if people cut down caffeine and alcohol, after a while, their mood tends to increase because they get better sleep. Okay, natural remedies. If you have, and I had this happen, I had a patient who had no money, had no health insurance, had no way to get treatment. St. John's wort is relatively cheap herbal supplement. St. John's wort has clinical trials out there and has been shown to elevate mood, has been shown to alleviate depressive symptoms. So and it does, like we mentioned earlier, it does have some contraindications with other substances. So if you're taking medications and taking St. John's wort on top of that, what St. John's wort tends to do is tends to kind of crank up your metabolism and things. Some substances you take, it's like you metabolize those more quickly, so they don't work as much. If you're taking an antidepressant, it's going to double that. It's going to be an additive effect. So St. John's wort can be effective by itself. Some of these others, I don't have, so I worked with a client who we brainstormed what can he do. And so he started taking this and he actually said, I feel better. He didn't get all the weirded out symptoms that sometimes folks that take Prozac, Paxil, Zoloft, report. Said he felt better. Some others here, some other supplements have each been shown to be more effective than placebos and are in some cases as effective as Prozac and imipramine. And so that's from a research article in 2011. I'd say St. John's wort is probably the most effective in that category there. And that, my friends, is it. I've got time for Rosa. Questions before we hear from Rosa? All right, gang. Thank you for your attention. I still never found the one med that is it Remeron? Quercetin, yeah, it is. That's it. Last thing, Remeron is one that to me doesn't cause like the activation as some of the others. And I think I've seen Dr. Feldman a long time ago at Meadow Lake use Remeron It's antidepressant, but it kind of takes the edge off and it lowers people's activity levels. So it's kind of like, it doesn't do that SNRI thing where you're working on serotonin, norepinephrine, and you're amping people up. That was it. Okay, that's all I've got. Rosa, are you ready?
Yeah, I think I'm ready.
Okay, I'm gonna shut this microphone off.
Okay, I have a question though. So if I do, I'm gonna play like a video, and if you guys can't hear it, can you guys just write it down so I don't have to play the whole thing?
Are you gonna show like the closed captioning, or what do you mean?
It's just like a little small intro video of somebody else describing a little bit of what I'll be talking about, kind of.
That's cool. It should come through. Most times the sound comes through.
All right, sounds good.
Okay. Thank you.
Can you see my screen?
Yes.
Okay, so I'm going to be talking about the mood stabilizers and how treating OCD, basically, like obsessive compulsive behavior. And then what are mood stabilizers? And mood stabilizers are often medication to treat bipolar disorder, schizophrenia, and obsessive compulsive behavior, which can be considered OCD. And then I'm going to be talking about a study later on done by some of the authors here. I can't say their last names, but they sound gibberish if I say it. But some mood stabilizers can take up to several weeks to reach their full on effect. I know how Professor Randolph mentioned it earlier. So
Hi, I'm Dr. Mark Faber, and now we will discuss the use of mood stabilizers, particularly useful when addressing bipolar disorder or, if necessary, significant mood dysregulation. These mood stabilizers include the more traditional mood stabilizers that are also referred to as anti-epileptic medication, or the second generation antipsychotics, which may also be used as mood stabilizers. The anti-epileptic medications include, for example, Lamictal, which is considered for bipolar disorder in the depressed phase. And with Lamictal, we need to consider that this is a medicine started at very low dose and adjusted upward slowly in order to minimize any risk of serious rash. While the
okay, how he said like they begin the dose at a very low dosage. I guess I can use that as a reference towards myself when they put me under Lamictal or Lamotrigine, what they call it now. They started me off on a 25 mg because if not, they said that you can easily break out in hives and rashes, and that's something that they don't want to do. So eventually they worked my way up to 100. And even if those patients lose or stop taking medication, the Lamictal, they will not start them off again at 100. On the other hand, they'll go ahead and begin them again at the 25 or the 10, just depending on the age of the child or adults.
Effective rash may occur with Lamictal. Serious rash is a much less likely outcome, and by using the lowest possible starting dose and adjusting upward slowly, this should help minimize this risk. In addition, other anti-seizure type medications which have been used in treating bipolar disorder may include Depakote. Depakote can treat bipolar disorder in the manic phase as well as the depressed phase, though Depakote does require blood testing to monitor a Depakote level, and also does require baseline and screening lab work to be certain that liver enzymes are unaffected. With Depakote, there may be some likelihood of weight gain as well, and stomach upset and fatigue may be common early side effects. A third anti-seizure medication which may be considered is Tegretol or Trileptal. This type of medication is sometimes used when treating bipolar disorder, and also a blood level may be obtained and tracking of lab work. With Tegretol, we know that Tegretol itself may trigger the liver to be more efficient in the way in which it metabolizes. And so the blood level of other medications given with, for example, Tegretol may go down somewhat. Now, shifting to other traditional bipolar type treatments, there is lithium. And lithium can be very effective for bipolar disorder, especially in the hypomanic or the manic phase. And with lithium also, lab work is done, particularly to screen and be certain that thyroid function testing, renal or kidney testing is fine at baseline and monitored during the course of lithium use, and that lithium blood levels are also monitored. Lithium, however, can also have side effects, and these may include being very thirsty, increased urination, a fine hand tremor, and it might potentially decrease thyroid output, and so these are things that are monitored closely. The second generation antipsychotics include medications such as Risperdal, Abilify, Geodon, Seroquel, as examples. And these medications may also stabilize mood. Zyprexa is another.
Okay, so then he just goes on and on about other things that really won't talk about what I'm talking about. Okay, so OCD, or obsessive compulsive disorder, features a pattern of unwanted thoughts and fears, really that can lead to repetitive behaviors. So a lot of it can, like with the obsessions, and sometimes it affects their daily activities, and that's what, like, I can reference that to that picture that's posted here. I know a lot of times, like, I guess when we were little kids, we'd be like, don't step on that crack, you know what I mean? Or you'll break your mother's back, or stuff like that. Or if we think about it now, it's like, oh wow, I didn't really step on the crack. Was it because of that, or with other things? Or your daily activities, just you have to have everything organized in a certain way, and a lot of times it can actually affect the way that you actually function on a daily basis, and can cause significant distress within one. There's a treatment plan. You can either do cognitive behavioral therapy, you can do the ERP therapy, which is now like exposure and responsive prevention, which is now becoming one of the main resources that people lean towards with OCD. And then now there's some individuals or doctors that are given to their clients mood stabilizers to help stabilize their OCD. And then I have a little picture right there. Cognitive behavior therapy will help the individual cope with any problematic changes that they have, whether that's their thoughts, their behaviors, their emotions, really activities. It associates between the sensations of distress of objects, as we can refer back to that picture, like how they had the ruler laid out in a specific way, Post-its, just everything. It can be the therapy can be either performed in a hospital or an outpatient setting. A lot of times, I know many people just go towards outpatient more than they would in a hospital. Treatment for OCD symptoms begin to improve. Studies shown that between an average of 10 months. And CBT also consists of having, like, with the OCD, like, you can also, I guess, use both of them, and then it actually helps lead towards the exposure, which is the ERP, the exposure response prevention therapy. Usually at this point now, they're using both of those and working together. They use the CBT and the ERP, and then they're using them within the same, I guess, in order for you to be able to continue to do something, they want to expose you out with it. So then it has become the new go-to therapy for OCD now. It also can be performed in a hospital and outpatient setting. It can actually like help improve, but it's up to the 2 years after your post-treatment. A lot of times after that, within the 2 years, people start going back to doing their usual habits. You know, you have to have everything in a specific way. It tries to aim and break the cycle of the symptoms by trying to eliminate the rituals. God, I can't talk. And avoid other aspects that will, you know, affect their actual routines and activities. The way that the ERP therapy is used is to teach clients how to tolerate and distress without engaging into the actual product and activities with their behaviors that they consistently do. They're trying to break the cycle. And then it actually tries to help and guide the clients with the challenges that they mostly fear with. And then I actually did a research and a study with the marble burning behavior. It is a pharmacological form of study that they use towards OCD. And then the three different medications that they used was the I hope I said that right. And then the lamotrigine, and then the carbam, that long one that the doctor referred to as the let me see, I wrote it down, as a Tegretol. So as I said, the study was performed by all their last names. And then they used 313 mice were used during this experiment. So they used different doses, and then they started off with 10, 30, 10, 100. So they increased as time went by. And then it actually helped reduce the marble burning behavior. So that's a good source of medication towards use towards OCD. So I don't know if you guys can see the graph, but it shows like, you know, how many marbles were moved and then how many mice moved them, or depending on differences right there. And then some side effects of the medication is nausea, vomiting, stomach pain, just really what the doctor also described. And then what really stood out to me is a lot of them also include the weight gain. So the lamotrigine, or also known as Lamictal, they only stuck with the dose use of 30. And then it also significantly reduced the number of buried marbles, which was a good outcome towards that. And then it also had side effects of, you know, like the doctor described, the rash, hives, swelling in the face. I know that happened to me, so they had to switch it after the 100, and I didn't go over that. And then painful sores around your mouth. And then it just depends. Everyone's side effect is different. And then the last dosage they used on this medication was 30 and 100. It did significantly reduce the number of buried marbles as well. So in all reality, the three main medications that are now being used for OCD are the, I don't know what's wrong with me. I'm having like, I guess I'm just nervous or something. And then also the side effects of the medication is the dizziness, the drowsiness, the nausea, the vomiting. And I know oftentimes the first couple of things that really, when individuals need to stand out, or when they told me, was like the drowsiness and really the dizziness, because that's usually the first sign out of a medication. When they gave it to me was, hey, they told me wait 15 minutes and see how, if you get dizzy, then let us know. And then those are my resources.
Nice. Very cool. Very good, Rosa. So I liked that you included the generic names. They're harder to say, but when I get, and I, you know, go back to the Lamictal and Tegretol, and I'll struggle myself in VPA. Valproic acid. I usually substitute those so I don't have to stumble, because I stumble on them too. So no sweat. You did the right thing by including the generic and not the brand name, because I usually say the brand name, and it's better. It's honestly better to say the generic. What questions do you have for Rosa?
I don't have a question. I just want to say you did a really great job. And I learned a lot because I didn't know a lot about OCD and the medications and stuff.
Yeah, I like that she included like the side effects and all that stuff. It's good to always know.
I'm glad she included the doctor's video. It's very straightforward, and here's your meds, and like I like that. I tend to go off down a trail. I tend to go off down a trail and don't just lay them out like that. So it's good to hear just laid out, structured.
I'd never heard of the marble bearing behavioral study.
I didn't either. That's why it stood out to me. And I was like, oh, at first it was stressing me out, honestly, because I was like, what is this? And then once I fully went on detail and had a little, panic attack, and call it good.
No, you did it. That's exactly what I'm asking students to do, is to find these actual research studies and, that show the efficacy of the substances. Either, they help OCD or they don't. I'll be honest with you, Rosa. I had been more familiar with like Wellbutrin and some of the SSRIs being used as treatment for OCD versus the mood stabilizers. So I learned something too. I learned a lot, actually, because I had generally associated a lot of times people with OCD as Wellbutrin or Zoloft. And so seeing these other medications has helped me, kind of broaden my horizon in how I view OCD. I like the fact that you mentioned the weight gain too. That with the medications that you're looking at, Lamictal, Trileptal, VPA, lithium, that's really the biggest complaint I've had from people who take them, and even the manufacturers. We had a Trileptal. I still have a pin. I don't know where it is now, but because the rep, get passed out all the swag that they do with the pharmaceutical reps. But when the Trileptal rep talked about it, he said, I have to actually mention this, and I can't remember whether it was Trileptal or one of the other ones that he was selling. May have been another one, but I have to say this really predisposes somebody to diabetes. He's like significantly, there's like a 4 or 5, I don't know if it's Trileptal, may have been the other, because he was pushing to several substances, but I know it was a mood stabilizer. But one of them it was like your rate of diabetes was like off the charts higher than normal. So, some is slowing down metabolism. It's trouble with, processing glucose. And so that's, when you take a lot of these mood stabilizers, that tends to be a common side effect is weight gain.
Does that mean it's a, oh, sorry, you can go.
I feel like most medications, the symptom is either weight loss or weight gain. Just, it's inevitable, I feel like.
Yeah.
Even birth control, like a lot of women struggle with, oh, well, this one will make you gain weight, but then this one has this side effect, or.
That's pretty common. Good observation.
I would say more gaining weight than losing weight. I've never heard of anything making me lose. Never mind.
Well, he'd mentioned earlier that some SSRIs can make you lose. Before that one, I actually hadn't heard of any making you lose either, but I guess they're probably out there.
Yeah, true.
I had a colleague who took Effexor, and she almost withered away. I mean, she needed like supplement to because she was she just would say, I just don't want to eat. I'm not hungry, and that's the SNRI.
Everyone?
Yeah,
Pardon?
But it was different on certain people.
some of the SNRIs could also cause low birth weight in babies in my presentation.
Thank you. Thank you. Yeah, she wasn't getting her nutrition. She just she didn't eat.
How was she not taken off of the medication then? What are the limitations to a point where someone can get so physically unhealthy that the doctor is like, look, if we can't find a solution to this, you can't be on this medicine?
She was at the low end of her healthy weight. So she wasn't classified as anorexic, but she was at the low end of her healthy weight. And so,
If she would have dropped below that weight though, would the doctor have intercepted, do you think?
I would hope so. She really, I don't think it was the weight loss that she really enjoyed. She just reported that if she didn't have it, I'm not right. That was her report. It is basically, this is helping me function. I get really down if I don't have this. And she did try to adjust, and she did work with the doctor to try to adjust, but she would also independently kind of manage and up her dose if she was having a particularly hard time. And I think that also, and very genuinely, if you're working, I know very few patients that are 100% honest, or I guess strictly adhere to their regimen, to what they're supposed to do. I don't know the percentage, but a lot of patients deviate, from what they're prescribed, and she was one of those.
So do not all antidepressants like depress your appetite?
No, the tricyclics and MAOIs, they cause a little weight gain. Most times the SSRIs, like Zolofts, the Prozacs, Paxils, they don't generally. Now they can. And the SNRIs, I would say they're more apt to. The Cymbaltas, the Pristiques, the Effexors, they're more apt to suppress an appetite.
Okay.
Have you read any studies or done any research on like the hormones that are in birth control that make you hungry? What parts of the brain they affect, just like antidepressants and stuff like that cause those effects? Because I've heard that birth control can screw people up way more than they let on or that anyone thinks.
I have not. I don't, you're making your body on some level think it's pregnant. So I know that's definitely messing with hormones when that happens. So I don't have a lot of experience because it's not considered a psychotropic med. So I couldn't answer that question. Well, gang, I appreciate your attention. We're running out of time. I'm gonna miss you guys when we end this, but I've appreciated your input. Good discussion again tonight. Next week we'll continue and press on with cannabis. Hey, 420. Hopefully we'll all still be here for our cannabis week. It won't be 4:20 in the afternoon, but it definitely will be the 20th of April. So in that case, everybody have a safe week. Stay indoors if you can. If you can't, I hope you stay well, and hope to see you in a week. So take care, buddy. Have a good night.
Bye.
Bye.